So there are so many corticosteroids available in the market. The classical first two things what you are seeing, cortisone and hydrocortisone, are the most commonly used. Hydrocortisone used for snake bite, allergic reactions, emergency. They can act faster. IV 100 milligram vial is there. 2 vials will be given if it is a snake bite or any immune allergic reaction or immune bite. The newer drug which is now orally given is deflazacort, and more popularly promoted. This is deflazacort. I told that the withdrawal reactions will be less compared to this. Okay, then we have the classical drugs, that is prednisone, prednisolone. The common trade name is Visalone. Okay, 1 milligram per kg body weight. Prednisone is most commonly used for acute urticaria, atopic dermatitis, so many, you name it, all type of allergic reactions you can use this prednisolone. Even it is used in children also. So triamcinolone, you might have seen ganglion or local intra-articular injections. We use this triamcinolone injections for ganglion, and sometimes for osteoarthritis they use these drugs, or in case of rheumatoid arthritis they use this intra-articular triamcinolone injections. Dexamethasone, betamethasone, over-the-table drugs. Okay, so most commonly used orally given drugs for asthma. IV injections of dexamethasone, betamethasone are given for asthma. They are used in combination with tafilin. Here you can see what are the equivalent doses. Okay, so deflazacort, prednisolone and methylprednisolone, all are having almost equal dosage. That is about 5 milligram equal dosage. Okay, so all of them are having 1 milligram per kg body weight dosage. Here you can see the mineralocorticoid property is not there with this prednisolone, prednisone or methylprednisolone or triamcinolone. So it is only present with the cortisone and hydrocortisone. That is like aldosterone-like activity. Okay, so this aldosterone-like activity will be helpful in some conditions. So what is the T-half? How long they will act? Okay, so it is in minutes. So hydrocortisone, cortisone, these are very short acting, that is 120 minutes is just about 2 to 3 hours. Okay, then we have prednisolone. It is also having shorter half-life, but prednisolone previously was used as 3 times daily dosage drug. Nowadays we don't use it, even though short half-life is there. We give it once daily dosage, because if we use this prednisolone as 3 times dosage drug, there is a chances of suppression of hypothalamopituitary axis. Okay, with this complication we are now avoiding the 3 times daily dosage tablet and we are starting with the morning dosage tablet. Okay, or the complete dose is given in the morning. So the most common use is nephrotic syndrome. So many conditions are there, we can keep on summarizing them. So what are the synthetic glucocorticoids? Synthetic glucocorticoids, we have alcometazone, that is topical, then beclomethasone. Okay, beclomethasone ointments are available for atopic dermatitis, fungal infections. Budesonide meter dose inhaler is there, so we have that for demonstration in our practicals. Okay, clobetasol topical, most commonly used for, have you seen clobetasol used in children? Where do we use? Well, there is a white skin patch on the face. What do you call this condition? It is due to the worm infestation, what we call it. So clobetasol topically we use it for the skin conditions. Then desonide is the agent, topical agent, newer one used for acne vulgaris. Then fluticasone, fluonisolone, Immunosuppressive, these are used as a nasal sprays for allergic rhinitis. Okay, fluticasone, Immunosuppressive and fluocinolone, all these are having topical and inhalational use. Coming to the biosynthesis. So we already summarized in the diagram what is the basic molecule from which cholesterol is synthesized. Okay, through a series of enzyme-mediated transformation, and this transformation is under the influence of ACTH. What it does, it simulates the adrenal steroid synthesis, aldosterone synthesis, is not directly stimulated but indirectly stimulated by the angiotensin 2, and ACTH stimulates the synthesis of the aldosterone precursors. Do you remember the aldosterone mechanism we have discussed while discussing the diuretics? It produces what? How does the aldosterone act? It produces aldosterone-induced peptides, from which aldosterone-induced peptides, the sodium and the potassium channels are just pass through their main prominent at the luminal side of the collecting ducts. Okay, just try to remember those scenarios which we have discussed. I will be telling them. So circulating potassium exerts a permissive effect. So aldosterone is called as a potassium sparing diuretic. That means it prevents the potassium from excretion. Okay. So what is the, can you remember those drugs? Potassium sparing diuretics, spironolactone. Spironolactone is aldosterone antagonist. What else? Amiloride, and one more. One is the metabolite of our spironolactone. What is that? Triamcinolone is there. Okay. So here the aldosterone antagonist is potassium sparing diuretic. What is aldosterone then? It will make the potassium excrete more. Okay. It will conserve the sodium and potassium is excreted more. Okay. Then only our antagonist can act otherwise. Okay. You are getting my point. Potassium sparing diuretics are aldosterone antagonists. Okay, you are getting. Potassium sparing diuretics are aldosterone antagonists. That means they conserve the potassium. Then what is the role of aldosterone? Conserve the sodium and excrete the potassium. Okay, it works in that direction. So circulating potassium, what it does now? Exert a permissive effect on the angiotensin 2. That means more potassium inside will trigger the synthesis of our aldosterone. How? By activating the angiotensin 2 stimulation. So high potassium enhances and low potassium diminishes the corticosteroid synthesis. So corticoids, 21 carbon compounds containing a steroid ring. Remember, what is the steroid ring called? Cyclopentanoparhydrophenanthrene ring. Okay, so this is the prototype structure. Okay, prototype structure of this prototype structure of this steroid ring. Okay, can you all repeat with me? Cyclopentanoparhydrophenanthrene ring. Okay, so this is the nucleus of all our corticosteroids. Yes. How it is regulated, we have discussed it. Just a summarization here. Regulation of the synthesis. The first and the foremost, we have the ACTH. Okay, which it triggers or it thinks what is needed now. Okay, it synthesis and release under the influence of this ACTH, and from where we get this ACTH? It is from the pituitary. And how the pituitary get inflammation? Hypothalamopituitary axis. Okay, here you can see the corticotropin releasing hormones, that is CRH. Okay, corticotropin releasing hormone that stimulates the pituitary to secrete this ACTH, from which this ACTH comes and acts on this adrenal cortex. Okay, this is the adrenal cortex. So from the fasciculata, what we get? GFR, glucocorticoid. From the fasciculata, we get glucocorticoid. So once glucocorticoid is there in the circulation, what it does? This cortisol is, or otherwise glucocorticoid, it can suppress the ACTH production from the pituitary and also to the hypothalamus. That we call it as feedback inhibition. Okay, so here it is regulated by corticotropin releasing hormone from the hypothalamus. So one more diagram to explain you, which can fetch you more marks in the exams. Okay, whenever there is stress in the body, what will happen? There is a stimulation of the circadian rhythm. Hypothalamus stimulus is there. Once hypothalamus is stimulated, you get the CRH release. Once CRH is released, you get the ACTH. From the ACTH, you get the hormones in the adrenal, glucocorticoid, catecholamines. They can act on this, what are the systems? Okay, immunosuppression, suppression of all types of WBCs. Okay, they can even lyse the lymphocytes. That's why we can use these drugs for Hodgkin's lymphoma or cancers associated with this lymphoma. Then in the muscle, what is the role? Utilize more and more glucose, break down the storage molecules. That is, storage molecules are glycogen to glucose. Okay, from the glucose we get this liver. Okay, from the liver, what is happening here? Again, you can think of two things here. Even the corticosteroid, they prevent the breakdown. Deamination is there, that is gluconeogenesis. Okay, that part you can remember. Then fat cells, they mobilize the free fatty acid and utilize them for glucose production. Then heart, increased heart rate. So, what type of receptors on which our insulin was acting? What we call those receptors? Tyrosine kinase receptors. Here we have something called as nuclear receptors. Okay, so we have the hormones. Okay, most of the hormones, like you take the all androsterone, androgens, estrogen, all these things, they will act on this nuclear receptors, and by the nuclear receptors they do the mRNA synthesis and thereby bring changes and bring about their action. So how is it possible? From outside the cell, here you can think it is a cortisol or a glucocorticoid. Okay, it enters the cell and enters the cortisol receptors, and there is a intermediate protein which is synthesized, and you can see this is a cytoplasm and cell membrane, from where our cortisol receptors is unbounded and enters the nucleus, where they act on they stimulate the DNA to produce the necessary proteins. So how exactly it is taking place here? So the first step, what you can see, is a protein carrier. Once a protein carrier is there, it cannot enter the cell. It is cleaved. The steroid hormone can enter the cell. Under the cell, inside the cell, we have a cytoplasmic receptor which takes inside to the DNA. Okay, that is the third step what you are seeing. Then transcription, translation, then new proteins are synthesized which will bring about our necessary action. So what is this? Translation produces new proteins for the cell process, and steroid hormones bound to the membrane receptors and use secondary messenger system to create the rapid cellular response. That is, all these steps may be bypassed in some of the hormones, so something like retina. So stress, this is the diagram. Okay, all three diagrams are there, which are you feel good, you can use those things. Okay, long term, short term response, as we saw with insulin. Okay, so insulin we told decreasing the blood glucose level as short term. For long term, what we told, gene synthesis, gene translation, gene morphology, and mitogenesis. All those were the features of the insulin. Here, for long term, what they do, they retain the sodium and water in the kidneys. So once sodium and water is retained, they can increase the blood volume and blood pressure. So these can cause steroids on long-term use. They can cause hypertension due to salt and water retention. So conversion of proteins and fats to glucose. So immune system is suppressed. So what is the mechanism of carbohydrate? They increase the blood glucose level, and what is the method? We call it as gluconeogenesis. Gluconeogenesis involves two processes. One is from fat, one is from proteins. So they peripheral action mobilize glucose and glycogen, and also acts on the hepatic glycogen. They decrease the peripheral utilization of glucose. Okay, they are helping in formation of glucose and decreasing the peripheral utilization. That means what will happen? More and more glucose will enter the blood circulation, so thereby they increase the blood glucose level. Here is what method you need. You feel maybe it is like insulin, okay? Because our insulin also promotes the abolition of glycogen in the liver, and here is our steroid, though it has all the other opposite actions, but promoting the storage of glycogen in the liver by activation of hepatic glycogen synthase. So one similarity between the lipid metabolism. Okay, what is there is a peculiar feature what we develop in case of the disease of this cortisol deficiency. Have you do you remember any disease? Cushing's disease, Addison's disease, okay, Addisonian crisis, all these things. What will happen? What is the role which causes this disease? We learn. Okay, what it does? Redistribution of fat. So buffalo hump, moon phase, promote adipokinetic activity. Okay, glucagon, growth hormone, adrenaline, thyroxine. All are activated by this corticosteroids. So mobilization of the free fatty acid will be increased. What is the role of this mineralocorticoid? As we have already discussed, aldosterone increases the sodium absorption from the distal convoluted tubule and cortisol, and once the ion is taken out, it is not coming alone, it is bringing some water along with it, so it becomes salt and water retention, and concomitant there is excretion of potassium and hydrogen. So this method is not by genomic method, okay, it is a rapid method by stimulation of sodium and hydrogen exchanger. So aldosterone induced peptides, have we discussed about this? Aldosterone induced peptides. So once the drug, once the corticosteroid or the mineralocorticoid comes and sits on this receptor, what will happen? It can produce aldosterone induced peptides. These aldosterone induced peptides synthesizes more and more potassium and sodium channels. Okay, we have discussed that while discussing about diuretics. So it affluxes potassium into the urine. So aldosterone is more important for salt and water retention, but by increasing the sodium resorption, increases the urinary excretion of calcium, potassium and hydrogen. So what is Addison's disease? Inadequate secretion of adrenal hormone. What will happen then? Inadequate secretion, there is no more sodium retention. No sodium retention means decrease, it will take out some amount of water along with it. So both sodium and water is lost. Once sodium and water is lost, the extracellular fluid level will decrease. Okay, then cellular hydration is decreased. So hypodynamic state of the CVS, because less fluid is available for the circulation. Okay, then there will be decreased fluid levels in the CVS. Then there can get circulatory collapse, renal failure, and finally death can occur. So finally, what will be the effect on cardiovascular system? Okay, we got to know that how it increases the sodium and water retention. Okay, so with that idea or with that aldosterone idea, we will see what is the cardiovascular effect. So it restricts the capillary permeability, maintains the tone of the arterioles. So once the fluid levels are more stressing of the myocardial muscles. Are you getting? When more fluid will or more blood is entering the heart, more stretching is there. So more stretching is there means more recoiling will be there. So powerful contraction for increased filling. Mineralocorticoid, they can also cause hypertension if they are used artificially and in excess. So sodium, what it can do, it can sensitize the blood vessels to the action of catecholamines and angiotensin. So thereby they stimulate the release of this adrenaline, that is aldosterone. So skeletal muscles, we told that there is gluconeogenesis, that is more glucose utilization. So if there is no corticosteroid, so how we can tell the mechanism is, if there is no steroid, what will happen to the muscles? So there is weakness and fatigue due to the inadequacy of the circulatory system. That means in addition that is happening means, so for skeletal muscle normal functioning or glucose utilization, we need this steroid. So if the steroids are externally administered for long time, they can cause steroid myopathy. That means they are needed for maintaining of the normal functioning of the skeletal system. So you know, a lot of quacks, they give steroid injections to get that euphoria. Okay, euphoria, and yes, that euphoric effect is on the CNS. Once the people who don't know what the disease is, they just go on injecting steroids to the patients so that more patients will come to them. Why this happens? Because once you inject the steroids, there is an elevation of mood or euphoric effect. Because the person is suffering from this fever, he will be depressed because of the fever, and body, it may be in the form of body pains, all these things. What happens to when we give the steroids? There is more glucose utilization, more blood circulating to the muscles, so he will feel elated. Okay, because of that feeling, they acute or temporarily they feel good. That can cause long-term myopathy, as we saw. So mood is elevated, brain excitability is there. They can, if used for long time, they can cause insomnia and anxiety. Okay, and bad part of it is they decrease the seizure threshold. That means the potential or the external threshold needed to cause seizures will be decreased, and that means more prone for getting seizures. So indirectly, maintain glucose circulation and electrolyte balance. Rarely, they can cause pseudotumor cerebri and raise the intracranial pressure. So what happens to the blood? We told that all the WBCs, they are suppressing, okay, but the other cells like RBCs, platelets and neutrophils in circulation are increased. Lymphocytes, eosinophils, monophils, basophils, their levels are decreased, or they can kill those malignant lymphatic cells. Okay, GIT, they can aggravate the peptic ulcer by increasing acid and pepsin secretion and decreasing the immune response to the H. pylori. So immunosuppressive action. We already know that glucocorticoids we use for immunosuppression, which you saw in the first slide. Okay, suppress all types of hypersensitivity and allergic reactions. At high dose, they can influence the most of the cytokine release and the allergic reactions. So we can use them for transplant rejection, but nowadays we have the more stronger alternatives. What are the drugs we use for transplant rejection? Any idea? Have you heard of tacrolimus, sirolimus? Okay, these are the drugs which are now used, but classical drugs are the glucocorticoids like prednisolone and all, which are used most commonly. Okay, if they are not responding to that, we will shift over to the other immunosuppressants. In graft rejection, decrease the antigen expression from grafted tissues, delay the revascularization and sensitization of the T lymphocytes. Okay, in all these allergic conditions, we can use this. So anti-inflammatory effect, how they bring it? They can suppress the T cell activation, decrease the cytokine production, suppress the mast cell degradation, decrease the capillary permeability indirectly by inhibiting the mast cells in the basophils. So reduce the expression of cyclooxygenase 2 and prostaglandin synthesis. Okay, so do you remember the cyclooxygenase pathways, arachidonic acid pathways from the phospholipids, membrane phospholipids, you get arachidonic acid. From the arachidonic acid, we get the action of the two enzymes, cyclooxygenase 1 and cyclooxygenase 2. Okay, from there we get two pathways. One is the leukotriene pathway, one more will be the cyclooxygenase pathway, where you get the intermediate products of prostaglandin I2, E2, F2, all those things. Okay, so here you can see the prostaglandin pathway itself is blocked. Reduce the prostaglandin synthesis, leukotriene, platelet activating factor or PAF, and phospholipid activity. Here you can see in this diagram. So what is happening? Membrane phospholipid action, phospholipid A2 that is suppressed, lipoxygenase pathway suppressed. So prostaglandins are